I became a surgeon to help people, to save lives, to save limbs, not to take them. And I got to tell you, I ended up doing so many amputations that it just broke my heart. I'm Dr. Lily Johnston, vascular surgeon and cardiometabolic prevention specialist. And today I wanted to take a few minutes and share with you some of my journey, how I got to this place, and why I am so passionate about helping you and all of my patients never ever need my surgical services. So, I grew up the daughter of two surgeons, and I was pretty sure I was going to be a surgeon too. It made really good sense to me, right? There is a problem, you do a thing, you fix the problem, people get better, they go on their way. Like, it's like a beautiful story. And there are some parts of surgery that definitely work like that. I wasn't clever enough to pick one of those. And even though the technical aspects of vascular surgery are still super cool, and the diversity of what I can do in vascular surgery, whether it's open surgery or something minimally invasive like a stent, whether it's in the neck or the abdomen or the legs, like that stuff is cool and I like it and I would choose it again within surgery. And I don't think I really appreciated just the magnitude of the metabolic disease that is causing the need for vascular surgery in this country and around the world. So I go through my training, get into surgical residency. I'm super pumped about it. I actually thought I was going to be a heart surgeon at first, like my dad. And as cool as heart surgery is, there were some things about vascular that really tweaked me that I thought were more fun and more conducive to the type of career that I wanted. And so, no shade to the heart surgeons, but vascular was what took my imagination away. And so off I went, and I finished my surgical residency, and then I went to fellowship. And fellowship was tough. Vascular was kind of new and different than my general surgery training. It was different skills, different types of cases, and it took a while for me to kind of get my feet under me. I know my faculty would agree. And then I was so focused on just mastering the technical part of it and the facts and the trivia and the stuff that's required to like get a patient through their operation safely and get them a good outcome. So I was really focused on that for a while. And eventually I sort of felt like, hey, okay, I've kind of got the rhythm of this. I understand what's happening. I understand, sort of the sequence for how I should try to help these patients who happen to have vascular problems. And then my fellowship was over and I took a job. I took a job in Northern California at a big multi-specialty healthcare organization, and it was great. I had super good partners, like the best partners ever. They were very supportive and held my hand and really took me under their wing to show me, how that practice worked and how we could help. So, started off going pretty well, and I felt like, okay, I kind of got this. Part of that practice, and it was just kind of how things had evolved over time in that particular organization, was that we did all of the amputations for that health system. So everybody in vascular surgery knows that amputation is one of the feared endpoints for the patients that we serve. And in fact, close your ears if you are not open to a little black humor and you would be offended by this. So take your time, close your ears. But there's a joke in vascular surgery that was common in our practice, and it went, the longer you're with us, the shorter you get. Give that a second. The longer you're with us, the shorter you get, right? Because ultimately, the joke goes, the end decision point of all of vascular disease is amputation. So that was like the black humor that underlied all of what we did. And beyond that, though, there are lots of people who require amputations for reasons that have nothing to do with poor circulation, or not, at least not circulation in the large blood vessels with names that I fix. So patients would show up with a terrible foot infection. They had a pulse in their foot. Their circulation in the big blood vessels was okay, but the infection was so bad that it was life or limb at that point. We could not save the limb if the patient was going to survive. And the most common reason to have an infection that severe is diabetes. So, in that practice where we did all of the amputations for the health system, we did our fair share for vascular disease, and that was sort of part and parcel of what I had been used to in my other training and experience. But we did an enormous number of amputations for patients with diabetes and foot infections. And it was a lot, right? And I kept seeing these patients who had insurance. They had a doctor who was supposed to be helping them manage this chronic condition. And I would talk to them about, what have you been told about your nutrition? What have you been told about the role of exercise? What have you been told about how to take your medications and how to help manage these risk factors? And it's not that their doctors didn't care. And it's not that their doctors didn't understand what the guidelines recommend in terms of the medications and the interventions and the escalation therapy for type 2 diabetes. But what I will say is that lifestyle change and education about the stuff that we talk about here on this channel every day takes time. And it takes a patient, working through a patient's willingness to change and where they are on a spectrum. It's called motivational interviewing, and it really depends on where people are and what drives them to make the decisions that they make. Not everybody is ready for change. That's okay. But there are many people who are, and they were not really getting good advice. They just weren't. And I'll tell you a story. I met a patient. We'll just call him Robert, and I met him in circumstances just like I described. Terrible infection in his foot up to his ankle, and we tried sort of treating the infection with antibiotics, and we tried for a few weeks to see if we could get it to a place where he didn't have to lose his leg, and it was ultimately unsuccessful. And I did his amputation and he healed up from that. But over this time period, he and I kind of got to know each other, and I met his partner, and we talked a lot about they had two puppies and two kittens at home. And I saw pictures of them and I showed them pictures of my cat. And we really bonded over our animal children and, the fun shenanigans that our fur babies were getting up to while we were, you know, seeing each other frequently. And so, I took care of Robert and he got better and he went his way. And I kept doing my thing and kept treating patients and seeing people in clinic and doing my thing. And I kind of keep a separate list of patients that I have treated. And every so often I open it up and just see how everybody's doing and see if anybody's in the hospital. And I saw him pop back up on the list. This is maybe 6 months later. And I thought, oh, interesting. What's going on? And I checked in the chart and he was in for another foot infection, his other leg, his good leg. And, Robert has a diagnosis of obesity. He has a diagnosis of type 2 diabetes. He has metabolic disease. And I was thinking, I can't amputate his other leg. I can't do it. Like, sure, if it's life or limb, will I? Of course. But like, I, I just can't see that. Like, I cannot envision his life. Like, how is he going to chase after his puppy? How is he going to play with his cat when he can't walk anymore? Now, can you rehabilitate? Sure. But you get the point, right? Like, we are talking about his second leg. Like, the first one is tragic enough, but this is his good leg, and he's got another wound, and his metabolic disease is still out of control. You talk to a patient like that, they will do whatever it takes to avoid an amputation or a second amputation. But this was my epiphany. Like, I cannot keep cutting legs off of people who have a treatable metabolic disease. And treatable means, yes, medications, but also the lifestyle things that we talk about. Eating for glycemic control and managing your insulin resistance, eating in a way that minimizes your insulin so that you control your blood pressure, so that you don't have maple syrup for blood that feeds infection. Using everything in our power, like walking and movement when we can, to improve the small blood vessels in our collateral circulation. So Robert did okay. He did not end up needing a second amputation from me, at least not at that time. But it was a watershed moment for me in my career. And it was, you know, clearly the primary care system is too overwhelmed to help these patients manage this. It is not the fault of their doctors. It is not the patient's fault. This is just the reality of the system that we currently operate in. And lifestyle medicine is a challenge. And there's a lot of bad information. So some doctors just don't know how to counsel their patients about how to eat to manage their type 2 diabetes, or what approaches are available when nutrition is insufficient that might be helpful rather than harmful, right? So there's a lot that goes into this. It is complicated. I am not trying to oversimplify it and say that only one intervention is what's needed here, but a holistic approach and a whole patient health conversation is missing. And it is costing people their lives. It is costing people their legs. And I couldn't participate in the same way anymore. So I got smarter and I consumed as much information as I could find about nutritional therapy and about exercise therapy and about the other pillars of lifestyle medicine and about other medications and about the diagnosis of obesity and about hormones. All the things, this all is one big picture. And it's really hard when our medical system divides people into different diagnoses, right? So, you have one doctor who manages your headaches, and you have a separate doctor who manages your routine OBGYN care. You have a third doctor who you see for your hormone therapy because your OBGYN doesn't do that part of OBGYN. And then you have a cardiologist who manages your risk, and you have a separate neurologist who manages your risk for dementia that's, inherited, and your primary care doctor sort of controls your blood pressure, but you see them once a year and you keep talking about, exercising more and hoping it'll come down. So there's like 10 different physicians or nurse practitioners or PAs or specialists involved in what is one person, but the specialists have a hard time coordinating that care in a big system or multiple systems even. So how do we think about this, right? It's probably not fair to expect everybody to get education in multiple different specialties, right? They picked one because one is a lot. But I do think it is important to educate patients and educate the public that all of these systems interact. Your diabetes is related to your obesity, is related to your anxiety and depression, is related possibly to your thyroid, is related to your vascular health. Like all of these things are connected. And there are several interventions that can treat many of those problems at the same time. So I got smarter. I went back and I did coursework and I did certifications and I attended conferences and lectures and wrote papers and tried to make myself as educated as I could. And then I had to figure out, in what way can I provide this to my patients? Because in a surgical practice, truthfully, again, there's not time. We are talking about a surgical problem and we have 15 minutes for that. We do not have the 2 hours that I typically will take to talk to patients about their nutrition and their exercise and movement and their sleep and their stress and their meaning and purpose in life and their supplements and their allergies to medications and their family history and all of these things that really matter for their health. So how do I do that? Well, it meant I really needed to make a pivot. So I walked away from that practice in Northern California. It was a full-time regular job. And I moved to Southern California to be closer to my family. That's another story for another day. But I moved here without a full-time job. I moved here with no practice, with no paycheck. And I started doing travel doctoring to pay the bills while I took all these courses and did the lectures. And I would spend a week or 2 weeks a month at a facility somewhere else, different state, different part of the state. And I would live in a motel room and I would be on call. And I had a lot of soul searching to do about what did I want? Did I want to walk away from surgery completely? Was it just that I hated surgery? And the answer to that is no. But it's that I needed to redefine what a successful surgical career looks like for me. And it requires a little bit of surgery here and there because I'm not so naive to believe that, at least in my lifetime, I will actually put myself out of business in surgery. I know that. So I will continue to provide the care and the compassion and the expertise that I can because I trained a long time to be able to do that. And that's an important part of who I am. And there are a lot of patients who come to me who have a lot of opportunity to improve their health before they ever need me as a surgeon, before they ever need a stent or an operation or a bypass. So I take those opportunities and I run with them. And I decided ultimately that I didn't see enough of those people and I couldn't help enough of those people. So I built a separate practice. Okay. That's called CoreSight Health. I am the founder. We are just getting CoreSight launched. And even that is still not quite enough because I'm only licensed in a few states, right? I'm licensed here in California, in Arizona, Virginia, and Minnesota. So I can help people there. But there are a lot of you who are actually reaching out and asking, how can you help me? How can we work together? And I am still thinking about what the best ways are. Part of it is this, right? Part of it is showing up here and providing these tips and tricks and my thoughts about what success looks like and how we get there to you on YouTube and wherever else. Like I'm on LinkedIn, I'm on Facebook and Instagram a little bit on TikTok. We're still sorting all that out, but I think this is one avenue to bring what I have to you. But I'm curious what else you would find helpful, right? I've thought about coaching, I've thought about courses, and I'm not sure exactly what is going to be most helpful for you guys, but I would really encourage you. I'm rattling around the idea of a course, but it's a lot of work and it would reach a lot of people and it would reach people that I can't serve as their doctor. But I want to do it only if it adds value for you. So do me a favor. If you would be interested in a course, just type teach me in the comments below, and then we'll keep track of who would be interested in that because I don't want to build it if nobody's going to listen to it, right? So let me know. What do you want to hear about? Is it nutrition? Is it understanding your cardiovascular risk, right? I know what I think you should have, you should hear about, but ultimately this is for you. It's not for me. It's for you. So let me know. Comment and teach me in the comments below if you would be interested in a course. Let me know what you want to learn about. Okay. Whether we make a course or not, even just telling me what you want to learn about helps inform how we keep making this content. On that note, this is a small channel. We are trying to get this good word out to as many people as we can, help as many people as we can, but we need you to help us do that. If you find this valuable, could you please hit that like button or subscribe to the channel, or maybe just send this to somebody in your life who could use a little support on their health journey, okay? Every one of those actions will help grow this channel and allow us to reach more people and help more people. If you could do that, that'd be so great. So that's where we are. We are working to figure out how to bring the message of prevention to as many people as we can, to help as many people as we can never need my surgical services, because the metabolic disease that caused the need for those amputations also causes the vascular disease that I treat. They are related, right? This is all related. And the earlier we start impacting people's risk factors, like their blood sugar, like their blood pressure, like their lipids, especially triglycerides, and sometimes the LDL cholesterol, if there's plaque, don't come for me, we'll talk about it. Everybody's different, but there are a lot of different ways we understand how plaque progresses. And each patient deserves an opportunity to treat or manage every one of those. So whether it's inflammation from visceral adiposity and a diagnosis of obesity, meaning fat around the organs, whether it is elevated blood pressure because they are salt sensitive, or elevated blood pressure because they're insulin resistant, whether it is an inherited risk for cardiovascular disease like Lp(a), whether it's an inherited risk for neurodegenerative diseases like an ApoE4 allele, which also, by the way, increases your risk for cardiovascular disease, heart attack, and limb loss. Any of these things, right, we have a slightly different presentation or phenotype, and we have a slightly different plan of attack. So this is very personalized. You, the one person I'm talking to right now, I may not have the plan for you available on YouTube, but my goal is to give you as much information about these risk factors, these different presentations, these different strategies as possible so that you can take this back to your healthcare team and figure out how to tackle these risks for yourself. Now, some people say, Doc, my doctor won't order those tests. My doctor won't talk to me about these things. I don't know how to, make the team work for me. And I think that's probably another video for another day. But what I would offer is you always have an opportunity to direct that conversation. You are not the passive recipient of the healthcare. You are an active, you know, orchestrator of your own health. And you get to come into your doctor's appointment and say, Doc, these are my goals. My goals are, and you get to say, right, whatever it is to, um, go to the International Crochet Conference in Whistler. It is to go take my dog for a walk until the day I die. It is to be with my partner on the beach at our annual honeymoon in Hawaii every year, right? Whatever the case is, you have some goals. You have things in your life that light you up, that bring joy to the world, and that you are passionate about. It is your goal to do those things. Now, how you get there is also up to you, right? Some people say, I don't care how we get there, like whatever it takes. Give me all the options. Let's talk about it. Other people say, I will change my diet, but I won't do anything different about my exercise. And that's not negotiable. Okay, fine. Other people say, I will take some medications, but not these medications. Okay. Other people's like, well, supplements are okay, but I don't want prescription medications. Fine. But these are your choices, and you get to take that to your physician and you can say, look, doc, I understand that there may be risks and benefits to this approach, but this is what makes sense for me. And this is what I would like to do. Can you help me with this? And I think most physicians will say yes. Some will not. And if they don't, I'm sorry, you should probably find a new doctor. I hate to do that to my colleagues, but we should be your partners, right? We should not be your adversaries. So my goal is to help you create allies in your healthcare team, not adversaries. And if that's just not going to happen, then maybe we need a different team. But ultimately, my goal is to help you express your goals to your team so that they can help you get there and that we can address the risk factors that will lead to heart attack, stroke, limb loss and amputation, and all of these things. So here I am today in Southern California, living close to my family. I have a 60% surgical practice at Scripps Clinic in La Jolla. And the rest of my time I spend bringing education to you, seeing patients in what is now CoreSight Health, and trying to build this community of people who are passionate about prevention, passionate about all of the interventions that are required to maintain optimal health for as long as possible. Thank you guys for sticking with me through that story. I know story time is sometimes a bit of a slog for people, but I just wanted to share with you because it's really a foundational part of my journey and why I do what I do. And somebody wise once said, people don't buy what you do, they buy why you do it. And so I want to share with you my why and ask you to think about yours because truthfully, your why is the most powerful tool you have in your health journey. It will help you stick through some of these changes that are sometimes tough. They are simple, but they are not easy. Your why is what carries you through that and allows you to make better choices so that you can continue to live your why. Okay, guys, stay tuned. Please leave in the comments what you want to hear more about. We will keep making this content for you as long as you keep showing up to watch it. And I hope you guys have a wonderful rest of your day. Take good care. We'll talk again soon.